Well, good morning, everyone. Good morning. I'm Stacy Robinson. I'm serving as the chairman of the board for the Montgomery Area Chamber of Commerce, and I welcome you to the State of Health. As we begin today's program, I want to thank each of you for being here and for your continued commitment to the Chamber's mission. Your support and engagement make events like this possible and pave the way for a stronger, more prosperous community. The Chamber is proud to be a bridge between our business community and elected leaders, working together to create opportunities and solutions that make life better for everyone. Healthcare touches every part of our lives. It affects our families, our employees, and our region's ability to thrive. By addressing the challenges of access, affordability, and equity, we can ensure that everyone has the chance to live healthier lives and contribute to a stronger, more vibrant Montgomery and River region. With dedicated collaboration between the public and private sectors, we've committed years of time and effort to enhance our local and regional community economy. Our goal is to keep driving that progress forward. We're honored today to have with us Dr. Lambiase with UAB Montgomery campus and attorney Ted Hosp with Blue Cross Blue Shield. I want to thank both of you for taking your time to engage with our members and guests this morning. We're excited to hear from you shortly. Now, before they come forth, I want to take the moment to thank everyone who has joined us today and extend a thank you to our sponsors for making this event possible. Our silver sponsors are UAB Hearseek School of Medicine, Montgomery Regional Medical Campus, and our corporate sponsors are Inspirian and Whitfield Consulting. We thank you so much. Would you all please thank you? I like when we can just make a phone call and they say yes, but thank you very much. Again, we thank you for your strong support in the Chamber and our continued mission to create prosperity for Montgomery. Many of our key partners are represented here today. Would all local and regional elected officials please stand? All right, several of y'all, you're all here. We thank each one of you for your leadership in our community as well. Now let's move on to the state of health. Dr. Lambiase has I don't have my No, I would just like to say I would like to actually just turn it over to Dr. Lambiase, and the floor is yours. I'm going to return it to you.
Well, that was unexpected.
What we were trying to do is to figure out the chairs between you. If you're going to be here or there. I believe you're going to be over there. Is that what we're doing?
We can do whatever.
I think it's better if you come over here.
All right, let's go over there.
And then you're going to.
I know, that's a problem. I'm under caffeinated.
I appreciate you.
High class outfit. Okay, I'll sit there, yeah. Now we got that ironed out. So I guess probably for those of you who don't know me, I'm Lou Lambiase. I'm the Regional Dean of the Montgomery Regional Medical Campus for UAB. I'm a gastroenterologist. We've been here about 3.5 years. Before that, I was at the University of Tennessee in Chattanooga as the chairman of medicine and assistant dean of something or other. And then before that, I was chief of gastroenterology at the University of Florida in Jacksonville. And so, you know, we were recruited, I say we because it's not the royal we, it's my wife and I, to try and help increase the physician workforce in this area and trying to grow the previous excellent work that my predecessors have done establishing the campus here and trying to grow medical care and medical education in this region. And then, you know, Ted, you want to introduce yourself?
Yeah, so, Good morning.
Good morning.
My name is Ted Hosp. I'm the Vice President for Government Relations at Blue Cross Blue Shield of Alabama. So I deal with health policy, both at the state and at the federal level for Blue Cross, and on behalf of our 2 million customers here in Alabama and nearly 3 million customers nationwide.
So thanks. So we're here to talk about the state of health. So that's we can probably get that banged out in about 30 minutes and get that. It's obviously a big issue, and there are a lot of different issues. And you know, I would say that the state of health in Alabama in general and in Montgomery in particular is complicated. You know, it's not for the lack of trying, but you know, I pulled some statistics off the internet just to show you some of the challenge. I guess we're 14th in the states in uninsured, so that's not 17% of our neighbors are uninsured. We have the third lowest number of physicians. We're the fourth worst in health outcomes. This is from a Forbes survey. We have the second highest death rate from stroke and pneumonia and flu. We're the fourth highest state in infant mortality. We have the 8th lowest number of primary care docs, and we're 51st out of 51 in psychiatrists. So, you know, so the state of health is challenging, but that's not without trying. I know in fiscal year 21, the federal government spent $22 million for rural health care in Alabama. The state government has allocated, you know, millions for training in rural, their tax credits and scholarship support to try and get rural physicians in. And you know, UAB, my colleagues at UAB have gotten at least $10 million in grants for private foundations for rural health care, and have really been innovative in trying to get primary care physicians out. So it's, you know, so it's not for lack of trying, and I guess that's really one of the questions is, you know, what could we do? What else could we do? How can we improve some of this? I mean, UAB is taking the Live Health Smart Alabama, where they've gone out and they've tried to physically change neighborhoods. They've been pretty successful in Birmingham, where they've gone out and looked at both physical impediments to people being healthy and other impediments to try and increase the health of specific neighborhoods and populations, and they just started in Selma. So I think that's very helpful. You know, we're trying to grow the workforce. You know, that 51 out of 51 psychiatrists. We're starting a psychiatry residency in July. We're pretty proud of that. We haven't quite figured out how we're going to pay for it, but it'll be all right. And so we're going with that. We're also trying to just have forum like this. You know, April 9th, just to put in a shameless plug, we have the Montgomery Health Policy meeting where we're going to talk about mental health. So it'll be at the RSA Activity Center. So, and I know my colleagues in Blue Cross and Blue Shield, and you've done a lot of work on the coverage gap and that sort of thing.
Yeah, a couple of things. First, you know, there is particularly in rural communities, there's a shortage of primary care physicians, nurse practitioners, mental health professionals. We've invested somewhere in the neighborhood of about $15 million in scholarships for physicians, and that includes primary care physicians, that includes OBGYNs, mental health professionals. We've expanded that scholarship program recently to include nurse practitioners as well, with the goal, the requirement for those scholarships, we will pay for the last 2 years of your medical school if you commit to spending at least 3 years in practice in a rural community in Alabama. And we partnered with UAB, we partnered with the University of South Alabama, and the VCOM and the ACOM schools, so all 4 of the state's medical schools. I will say, particularly in rural communities, and you know, I want to obviously focus on Montgomery also, but in rural communities, it's very hard to attract primary care providers because rural communities tend to have a higher percentage of uninsured individuals. And if you think about it, an uninsured individual, obviously their only access to health care for the most part is through an emergency department. It's not through a primary care physician or nurse practitioner. And so asking a physician to set up a practice, hang out a shingle in a rural community where there are a significantly smaller number of people to start with, and a higher percentage of those people who don't have access to quality, affordable health care, it's problematic. So it is something that we need to focus on as a state. There are a lot of changes going on right now in the healthcare environment at the federal level. I don't know if we want to talk a little bit about that, but you know, the budget discussions that are going on right now, and there was a flurry of articles, I was talking with the doctor earlier, a flurry of articles that came out really last night and this morning talking about where they might go to cut budgets. And a primary program that is on the chopping block at the federal level right now is the Medicaid program. Obviously, President Trump, during the campaign, and he's continued it through in office, has promised that he is not going to cut Medicare or Social Security. That leaves very few programs that where you can go and make some cuts. And obviously, with the extension of the Trump tax cuts slated to be reenacted, there is a need to find some savings in other places. One of the things that's on the table, for example, is to move the Medicaid program nationwide to a block grant per capitated program. I've just done, and this is the last thing anybody needs is for me to be doing math, but I've just done some back of the envelope math as to what that would impact, and my estimate, again, don't take this to the bank and the press don't print this, is about a $900 million cut potentially to Alabama in terms of federal funds for the Medicaid program. So a pretty significant change. I think it's very clear that we'll see Medicaid work requirements implemented across the country. That honestly I don't think would impact the Alabama program all that much because, as you know, an able-bodied individual who's not a caretaker in Alabama has, there's no income threshold at which you qualify for Medicaid. So if you're able-bodied and single and don't have children, you do not qualify in Alabama even if you make $0. So I don't know that a work requirement would have that much impact, but so there's a bunch of different things going on. The ACA subsidies is another issue we can talk about, but I know that the cuts and potential cuts are obviously going to have an impact on UAB as well.
Yeah, I think we're still sort of figuring it out. I mean, the biggest news that came out just recently was a change to the overhead for NIH for research funds. You say, well, why would that affect anything? Well, what happens is that, you know, the money obviously is fungible, right? So what if UAB, for example, gets funds from the federal government and they get overhead and they support their bricks and mortar and that sort of thing, that's money that they can spend elsewhere. So one of the things we've been successful here in Montgomery is redirecting some of the support that Baptist sends to Birmingham for UAB to redirect it here to develop programs. And you know, obviously my worry is when the money dries up in Birmingham, there's going to be less flowing back down, and so we're going to not be able to afford programs. You know, so for example, we just received a grant from the city to do street psychiatry, to go out to people who are homeless and try and bring their psychiatric care to them, make sure that they get their medicines and that sort of thing. And that covers about 70% of our costs, but the rest of it UAB was bearing through these funds. And so, you know, I'm going to have to look hard at not doing it if there's no money, to figure out where we're going to do it. And I guess that's one of the things about this when we think about cuts and people who are uninsured and somebody's paying for their care, right? I mean, so if they get whatever care they get, somebody's paying for it, right? And a lot of times it's us because there's a cost shifting that goes on. You know, our health insurance is up, or we pay subsidies to hospitals, or hospitals have to have 20% of their patients that don't pay, and then all of a sudden they're failing, and then all of a sudden we have to give them millions of dollars of tax dollars. So somebody's paying for the care, and I think that's one of the important things to think about is, you know, how do you do this since you're already paying for it, how do you do it in a smart way, and how do you do it in a way that it enables people to get back on their feet and that sort of thing.
Yeah, and from that perspective, you know, a lot of folks have asked, so why is Blue Cross involved in, you know, looking at a potential for closing the coverage gap, making sure that we have folks who have access to quality, affordable health care. First of all, that's our mission. We believe that everybody should have access to quality, affordable health care. We would prefer that it's through us, of course. but we understand that that's not where everybody is going to get that coverage. But as the doctor pointed out, a hospital that is treating, let's take a rural community hospital, where the uninsured rate at hospitals, the uninsured percentage of a hospital in a rural community, it's about 20 or more percent, as the doctor said. If you think about it from a perspective of a business, could any business survive if 20% of the people to whom you were giving services, if you were a lawyer, if you were Walmart, if it's 20%, how could you stay in business? Well, one of the ways you would stay in business is you would charge your other customers more. And there's no secret to that. I'm not accusing anybody of doing anything wrong. Hospitals, though, do say very openly, when we have to treat 20% of our customers for free, we have to go to our other customers and ask for more. Now, you can't ask for more from Medicare because that's the federal government. You really can't negotiate that price. You can't really ask for more money from Medicaid either. And that leaves the commercial market. That's the only place where you can go to make up that money if you're a hospital is having to essentially give away 20% of your services. So from that perspective, it's beneficial to our customers to make sure that people have coverage. The other thing is that when we place a strain on a hospital, regardless of the community in which that hospital is located, and that hospital may have to shut down services, whether it's maternal care, childbirthing services, or just shut down altogether. While we don't have a large percentage of our customers in rural communities, it's usually, remember I said it was about 20% in a rural hospital, it's usually about 7 to 9% Blue Cross customers. It's a pretty small percentage. But our customers need those hospitals. And so when a hospital in a community closes, it doesn't just impact the uninsured, which is their only source of health care. It impacts everybody. And Dr. Williamson made this point, I think, in an interview last week. When a hospital closes, it doesn't just close for the uninsured. It doesn't just close for the Medicare patients. It closes for everybody, including our customers. And it's important to us as a company, it's important to our customers that those hospitals are there for our patients when they need them. So.
At least some sort of care out in the communities. You can argue, what it should look like, and I mean, right in my world, the more procedures you do, the better you are at it, the better the outcomes. So does it, one of the questions I always have with rural is healthcare is, does it make any sense to have an operating room where you do 15 cases a month, or would it be better for people to come to higher volume centers? And I think people vote with their feet if they can. So that's the other thing. And so one of the things I want to point out too is that this the uninsured population not only puts a pressure on the hospitals, but it also makes it hard to recruit doctors, right? Recruiting doctors is a national game, right? So when I try and we have about 50% of the gastroenterologists that we need in Montgomery. So if we're trying to hire a gastroenterologist, we're not just competing against Jackson or South Alabama or something like that. We're competing in Mississippi, Florida, all throughout the states. And so if you think about it, and you could argue about cost of living, but most people don't think about that. If you could do the same job and get paid 20% more in another state and it's nice here in Montgomery, we really like it, but there are other really nice communities. Where would you choose to go? And so that's one of the problems we face, and that's why we're chronically behind, which is why it's hard to get in to see a doctor, which is why, so there's a spiral effect to this that we're all already paying for. I guess that's really my point on this.
Yeah, all true, and obviously we're happy to take questions at some point too, but I will say this, because now we've all just told everybody all the problems that y'all already knew we had. So, thank you very much. What can you do, right? I mean, that's the question. What can we do as a state? I think it's going to be hard to address a comprehensive solution until we have a better picture of what's going on at the federal level. We, as a state, we have limited resources. We know that as a state, the budgets are changing. We're coming out of the COVID period where the federal government was sending an awful lot of additional resources to us as a state. Those COVID relief funds that came down had to be committed by a certain date, and they have to be out the door by another date. And all of that money has been sitting in a state account drawing interest, but that interest is going to stop as that money is spent. And so while we have been in very positive budget cycles over the last couple of years, which is a strange sort of consequence of the COVID crisis, that is going to change. So at the state level, we have a constriction potentially of some of our budget available. And then you throw on top of that what's going on at the federal level, and some question as to what are we going to be doing with healthcare funding at the federal level. It's going to be hard for us to know what exactly we need to be doing here to address these problems until we get a little more certainty at that level. Now, that said, in terms of what you can do, I think, if it matters to you as a community, I know you're here, so it does, speak to the members of Congress as they're going through and making these decisions to make sure that they understand where you are on those changes. One of the changes I did mention earlier, but I didn't talk about, it's not actually getting a lot of attention right now, is the subsidies available on the affordable care market right now. As a non-expansion state, primarily, we have seen pretty remarkable growth in the individual market here in Alabama, primarily as a result of enhanced subsidies that were put in place during COVID that expire at the end of 2025. And I'll just give you some real quick numbers to sort of let you know. In 2021, let me go back to 2020. In 2020, we had about 170,000 people in the Affordable Care Act market here in Alabama. 170,000 people. 2025 enrollment is close to 500,000 people. So you're talking about a change in the ACA market from 170 to almost 500,000 people. Those are people primarily who would have been uninsured prior to. Now we're projecting, if the subsidies are not extended, again, they expire at the end of 2025, by 2027, that almost 500,000 number will drop down to about 240,000. That's 260,000 potentially new uninsured Alabamians. It's a huge number. As a result, again, if the subsidies are not extended. Let me make it clear, that's not something that's on the table that Congress would be quote-unquote cutting. Doing nothing, those subsidies would actually expire. So those would have to be affirmatively put into a bill that extends it. I'm not overly hopeful, honestly, given the level of, and again, I'm not criticizing Congress. We have unsustainable levels of deficit. We have unsustainable levels of debt. That we cannot continue to spend money at the rate we are spending it, given that we simply do not have it. I'm simply pointing out, when cuts are made, it will have an impact here, and just want to make sure everybody's aware of that. Again, to the extent that healthcare is important, those are conversations that we need to be having with our elected officials. They have very hard decisions to make, both at the state level and the federal level. And I think healthcare is among them in terms of the hardest ones that they have to deal with.
I could see the frustration on this on both sides, because significant resources have been committed to this, and yet here we are. And so, part of it is, I think you have to be really bright to try and figure out, is there a different way of doing it? And I actually don't know. I don't know the answer. I mean, you're doing the same thing probably is not the right thing, and try not to hurt. Try not to do anything that's got unintended consequences would be nice. One of the things that happened during the Reagan administration, for example, was this move to shut down and sort of mainstream people with mental illness. And so a lot of the mental hospitals went away, funding for mental hospitals went away. And, we all saw One Flew Over the Cuckoo's Nest, and it was, just horrific. But one of the things that happened is that an area where people who are mentally ill and psychotic can't get, shelter, housing, and their medicines on a regular basis. And so then we've had an explosion of people, on the street from that sort of thing. And I think it was all well intentioned, but I think it's one of these things where you have the sort of a right idea, plus you're saving a few bucks, and then you look what's happened, and now we're trying to spend money to try and figure out how to put the toothpaste back in the tube. It's just a hard thing. So.
I don't know, do we want to have any questions? How do we want to proceed? I'm happy to keep talking as anybody knows.
Yeah. I'll start and
Yeah.
ask you another question. So it feels like we may need part 2 of this series because there is so much to cover. In working with our economic development consultants that we deal with, and one particularly right now that's doing some economic update for us, are there other communities you're aware of, and we've got him also doing some homework on, what are local communities doing to take kind of their destiny into their own hands in terms of healthcare authorities, local revenue funding for indigent care and those kind of things, where the local leadership, because you cannot always be at the mercy of the feds and the state. Do you have some success stories like that? And is that just what's your perspective on us having that conversation in Montgomery?
Well, certainly I think the conversation makes a great deal of sense, and obviously healthcare authorities is an avenue that a lot of communities have used in Alabama. It does free up communities to be able to dedicate resources to healthcare in general. I think it's hard to find a community that's done a better job at healthcare in Alabama than Birmingham, obviously with UAB. It's kind of that center jewel. And their ability to care for that community. Obviously the Huntsville Hospital up in that community is extraordinarily active and engaged, not just in Huntsville, but in the region through that healthcare authority, and an ability then to look out not just for a specific hospital, but for a region as a whole. Unfortunately, it's not an area that I'm an expert on by any stretch. Like there's an area I'm an expert on, but it's not something that I'm as well versed on, so I apologize for that.
The 2 previous communities that I lived in, Chattanooga and Jacksonville, both the counties had stepped up and tried to, get the coverage gap between people who were, for one reason or another, not eligible for Medicaid, but were unable to be insured. Sort of the working poor, and they both had programs, and it was both at the county level is where they did that.
Hospital?
Yeah, there were counties. So in Chattanooga, there's Erlanger is the Hamilton County Chattanooga Health Authority, and they have some funding through county lines and state lines where they're able to take care of indigent care, and then in Jacksonville there was actually state and city of Jacksonville, which is the county as well. They're unified, was also paid through tax dollars. And so in Jacksonville, they actually created an insurance product using our colleagues at Blue Cross and Blue Shield in Florida called First Care, where they basically put this product together where you got access to primary care and you got some limited access. So as a specialist, we had a capitated rate, but there was some limited access at the county, at the University of Florida, what's now UF Health Jacksonville, but had historically been the public hospital, and so we took care of it.
Yeah, we've looked at, sort of at the request of the state, is there some sort of limited coverage that could be created, whether it's access to primary care or that sort of for folks who are in the coverage gap. And it is possible, of course. It just depends on how much money you want to spend. It's very much harder to do when you're not drawing down the matching funds from the federal government, just because, you know, under an expansion type program, it's a 90-10 match. Even under the Medicaid program, it's a 28 at the state dollar and 72 federal. So, you know, that multiplier effect, it's very hard to replicate it at the local level.
On the back, can you tell us about the current programs that UAB has here in Montgomery? And are there opportunities to expand those programs?
So UAB here in Montgomery, so we've had an internal medicine residency in Montgomery for 50 years. So, you know, we graduate roughly 8 or 9 internal medicine residents a year. We have about 20 medical students per year for the 3rd and 4th years, with the idea that we'll double that class eventually. So I think Dr. Manny was the founding dean for the campus. I think they graduated their first class in 2016, so they've had 8 physicians come back to practice, and I guess we've got about 20, 25 internal medicine specialists throughout Montgomery. We're starting the psychiatry residency. That's our first class. The match is in March, so we've interviewed them, and now we're just going to see who's going to come here in July. Like I said, we've got the street psychiatry, and so, you know, our main focus is physician workforce. And so and a little bit on policy and that sort of thing. And so, like I said, we've got the health policy meeting coming up April 9th. And then we've got, our hope is, because, you know, surgeons are getting a little bit older here in town as well, I'd like to put a surgery residency tract here, and then an OBGYN residency tract, and then, you know, I may retire before it happens, but a pediatric residency as well. Because one of the things, like I was in Chattanooga, Erlanger has 14 residencies, and they just don't have the same shortage of physicians, right? I mean, I was chairman of medicine, half of the internists in town came from our program. Almost all of the surgeons in town were from the program. You know, you can go through it all with all of the things. And so that's our hope here to do it. You know, and I think eventually we'll get involved in some clinical research and expand the medical care. The other thing that UAB has is a multi-specialty clinic. So we have physicians who practice in not just psych and internal medicine, but gastroenterology, rheumatology, cardiothoracic surgery, urology, breast surgery. Did I say? Endocrinology. Yeah. So, and they're all UAB specialists and part of UAB faculty that are here practicing medicine based here in Montgomery. So that's what we do.
Yeah, I mentioned earlier our physician scholarship program. One of the reasons why we require 3 years in a rural community, and you know, I think residency programs will maybe have at least the start of this effect too, is the studies show that if you spend 3 years in a place, you're very likely to stay there. And so when you can attract physicians to a community like Montgomery through the residency program, the great hope is obviously that they'll stay here. And you mentioned that with Chattanooga, that's what you saw. So
52% of the physicians who train as residents in Alabama stay in Alabama. And that's higher than medical students. And if you think about it, it's the time of life, right? They're a little bit older. They're getting married. They've got children, and they're starting to get in the community. And to me, that makes a lot of sense.
Hey, I have 2 questions, and I'm not an expert or anything. But can you talk about using nurse practitioners and expanding their scope to function at the level that they're trained to do, as they are in many other states, and then talk about the need for geriatricians, which we have 4, I think, in the state with the aging population, and the way they're needed as we watch baby boomers march into long-term care.
well, so on scope of practice,
That's not nearly as
let's start. That's very fun. Let's start on scope of practice first, and you know, kind of I mentioned this earlier. Scope of practice, and we see a lot of different specialties and caregivers who are seeking the same thing as nurse practitioners are, which is the phrase we hear a lot is practice at the top of your license, have the ability to do more services. We look at every single, we try to, first of all, let me say, we try to stay out of scope of practice legislation or regulations at Blue Cross and Blue Shield of Alabama, because a lot of times that puts us between two different types of providers, whereas a specialty, whether it be a nurse practitioner or a doctor or a podiatrist or somebody else, maybe on the other side of a physician. So we do try to stay out of it, but we do examine each proposal and look at it from the perspective of how is it going to impact a Blue Cross customer's access to care, quality of care, and cost of care. We are big proponents of care extenders like nurse practitioners. We think, particularly in rural communities, that can be a person's only access to care. So we do favor, and I know that there was a change recently with respect to supervision of nurse practitioners and the ratio in terms of hours and of supervision for a doctor. We're in favor of measures like that to make sure that we can have access to that type of coverage. So we're always looking at it. We think it's, again, we think care extenders have a positive impact on quality of care and especially on access to care. And on the second question, which I probably can't even pronounce the word you used, but it sounds like, but obviously care for our aging population, incredibly important. That sounds more like a recruitment issue and training issue that we need to
well,
focus on.
there's a national shortage of geriatricians, right? And I will say that a well-trained internist can get you 90% of the way there, but so I think that that's good. But you know, the problem is that the way we pay for training is kind of strange in this country, right? So it costs roughly, I think from the Baptist cost report, it's about $120,000 a year to train a resident, roughly. So that some of that is the cost of the resident, and you have to pay them benefits now and stuff like that. So we have to pay them a salary and benefits. And then some of it is the instructional costs and the overhead that goes along with it. The problem is that all of that money comes from, almost all of it comes from CMS, right? It comes from the federal government, passed through the hospital, and then paid to whoever the sponsor of the program is. Some hospitals have their own program, and some hospitals contract with medical schools like UAB and that sort of thing. And what happens is we're sort of capped. So there's a cap where no more slots are available in the country. So you can't get paid for anything where for any more training slots. What you did in like 1997, I don't know the exact, but it's 96 or 97. So for example, Baptist has about 50 trainees, but they're getting federal funding for 16. So that if you do the math, right, there's all of these people that they're paying for trainees. This is part of the mission. And so when I go to them and say, hey, I'd like to add 50 more spots, you know, that becomes like, you know, don't let the door hit you in the back, because you know margins are tight, and as we just said. So that's why it's hard. Even if I wanted to train geriatricians, even if I was able to, it would be hard to do it, and that's what we're looking at in the country. But yeah, it's geriatricians. There's the tough thing in the country is we put a lot of, rightly so, we've put a lot of emphasis on primary care because there's a deficit in primary care. But almost all specialties around the country are also in deficit too. There was a McKesson white paper from before COVID that said there was an equal number of specialty things. So I mean, it's something that we have to work towards. You know, I think in certain areas with appropriate guardrails, you know, physician extenders, nurse practitioners are good. You know, one of the things I always worry about is like my new colleague who joined us in gastroenterology. He went to medical school. He did an internal medicine residency for 3 years, and then he did a GI fellowship. So 6 years after medical school before he could do gastroenterology, and yet you could theoretically hire a nurse practitioner with a year of experience and put them in a GI clinic, right? And so and my colleague's not stupid, so it wasn't remedial work. I mean, he learned a lot. And so I always worry about, you just have to have appropriate guide rails and that sort of thing. But I think that's one of the strategies I think we're going to have to do.
I've got a question. We have all had the problem of trying to make an appointment. But let's say after an audit, we might be seeing next year in June. How many of you have ever come across this problem, how long it takes you to see it? That's got to be the majority. So what we need to work on, and what I would question is, what are the three major deterrents for us getting physicians here? We have got a massive shortage of doctors, and frankly, as far as I know, in every area. And then I have a quick question for you, because I could be really misinformed on this.
Sure.
When we're looking at why we don't get somebody, and those reasons, and I think you have to identify those in order to fix those, to work on. Does Blue Cross Blue Shield, do you pay the same thing for a service or a here as you do, let's say, in Georgia? Is that level across the board? Or are we competing with other states because they get more money?
Yeah. So Blue Cross Blue Shield of Alabama is an Alabama company,
Okay.
and we negotiate rates with hospitals and physicians here in Alabama. There is a separate Blue Cross of Georgia that is actually an Anthem entity that then negotiates totally different companies. Now we do, to the extent we're allowed to, we do checks to make sure that we are tracking in terms of reimbursement on both a regional and national level to make sure that we're staying kind of in a range. One of the concerns, and we hear it all the time, obviously, from providers, whether it's hospitals or doctors, is they understandably want to have higher reimbursement rates. And we're in a balancing act at Blue Cross, as every health insurer is, and that is as you probably know, Blue Cross Blue Shield of Alabama is a not-for-profit company. We don't have shareholders, we don't pay dividends. We spend typically about 92% of our premiums on healthcare, directly to doctors, hospitals, pharmacies, etc. So we're not in it to make a profit, just run the shop, make sure we can provide health care. What that means is that every dollar that is increased in terms of reimbursement has to be absorbed by our customers. And so while obviously our physicians, our hospitals, our pharmacies, again, completely understandably want to have higher reimbursement rates, the flip side of that is our customers are continually seeing premium increases. And that's based on a number of different factors, the cost of care. We're seeing especially an increase in cost of care on the prescription drug side. That's probably our fastest growing piece of our premium dollar. Some of that's good because there are remarkable new therapies that have become available, but most of the remarkable new therapies that have become available are remarkably expensive. So I hear you, and again, we hear it consistently, as the doctor can imagine, from our healthcare providers, but we do have to balance that with our premium payers because we don't have any other place to put that. But we do also hear, again, as I mentioned earlier, we know that the physicians in the hospitals and the pharmacies, they can't negotiate with Medicare, they can't negotiate with Medicaid. So we're kind of the first line of, hey, we need to attract more folks. But we do market check to the extent possible. We're not allowed to ask what someone else's reimbursement rates are. There's reasons why we can't do that. But we do make sure that we're within range of kind of where we are regionally and then also nationally. So now we're going to have lower rates than a New York or a California or a place like that. In some instances, yes, and some of that will depend on how big the healthcare payer is, how many members they have. But there was the original part of the
Yeah,
question.
the original part of the question was on barriers to recruitment. That's a complicated question, right? I mean, why, some of it probably is money, but there's probably other things too. Remember, it's a national market, right? So every physician who graduates from the training program has the whole country open, right? And so, and every day, even I, as a superannuated gastroenterologist, I get 4 or 5 solicitations to go practice somewhere else. And so, it's a very competitive, very tough market. And so, and it's hard to know exactly what it is. That being said, we've been fairly successful in terms of recruiting. Julia Hennick sitting back there, she does the recruiting for Baptist. How many physicians have you recruited this year? I mean, it's been at
It's
least.
been a good year. We bring in probably 25 a year.
Yeah.
But we've signed a lot of people coming this summer.
Yeah, and I mean, in even our campus, we've hired 4 internists and then 2 family medicine doctors in Selma, which isn't part of our campus anymore, and the psychiatrist. So I mean, you can do it. You can do it. I mean, it's not without.
And it's interesting. I do think money obviously always is a factor in anybody's decision about where they go. But part of my job at Blue Cross is to be involved in economic development on behalf of the company and workforce development, that sort of thing. And one of the things that we're looking at from as a statewide perspective is what are younger people, in a physician's instance, it's not necessarily a young person because you do have those 6 years of schooling after. But what attracts those folks to a particular community? And I'd encourage you, there's a whole lot of stuff that's going on through the EDPA and the Department of Commerce. But I think all of those things are relevant when you're talking about attracting healthcare professionals as well. And it is a lot of stuff like outdoor activities, hiking trails, biking trails. The Whitewater Park here is, we hope, obviously is going to attract folks to this community. And well, again, I'm not discounting the money factor also, but what a community has to attract people and highlighting that in the presentation and the recruitment process, I think, is critical.
Yeah, the other thing where I've seen success is it's a lot easier to recruit physicians if you've got a training program to recruit into for a lot of different reasons. So we really, we stood up a gastroenterology fellowship in Chattanooga, and then we were able to recruit quite a number of gastroenterologists. And there are some reasons that are kind of sound trivial, but the trainee takes the first call from the ER, right? So you're not up all night if you're an attending physician, and that makes a big quality of life thing. The other thing, though, I think, and you touched on this with young people in general, but is career development, right? So one of the things that UAB specializes in is paying people less so that they can develop their career. And so I think, I think, being a little facetious, but I think that if one of the ways we've been successful, all of those people I told you that we hired, is we've talked to them about how are we going to grow your career here. And so that's why I think the training programs, a lot of them want to be educators. If they're in Montgomery, that fits the best. And so the idea of, I want to make a difference. I want to give back. I want to do something intellectually interesting. And so I think that's one of the ways that you overcome this. At least that's always been my strategy. We're talking to a surgeon from UAB maybe to come down and join us, a colorectal surgeon. And one of the things that's really important to him is, what am I going to do with the university? And so, we're going to create a program around that. And so I think that's an important, where UAB can be a real resource for the community.
Y'all are too quiet.
I truly hesitate to bring up any topic, because at my age, you don't want to sound like a crank.
It's too late.
I've talked with Todd Strange, who has been extraordinarily supportive for many, many, many years of medical education in Montgomery. Current tuition to walk in the door at UAB School of Medicine, just walk in the door, sit, have a chair to sit down, is $36,000 per year. That's not eating the first meal, buying the first book. That's just having a spot to sit down. The average medical student graduates with about $200,000 plus in debt, and that clock starts ticking when you graduate. So you have to start paying back during your residency. So that's another deferred 6, 7, 8 years. So when they leave training, they're fully ready to start. They have a lot of debt. And one of the challenges that I've always seen, and this is for the community, is public education. You can go to Vestavia and send your children to public schools. You go to Bunbrook, go to public schools. The hot place now is Fairhope. I mean, I think Fairhope's going to turn into the new mecca of medicine. Madison and outside of Huntsville. And you can still go to public schools and not pay $18,000 per year per child at a private school. So that is something as a community can be done. That is something that we who have an interest in this community can speak up and say, this is a problem, this is a challenge. And it's not just unique to medicine. It's unique to lawyers, dentists, other professionals. And looking with people with small children who are graduating with enormous amount of debt. Some of it is unsecured, i.e. credit card. So my piece.
Yeah, and that goes to recruitment, right? If you're recruiting a young physician who has a family and you're looking at maybe you do have some debt, you know, what is the education system like, and where are your children going to go to school? And does that increase the cost if you don't feel comfortable sending them to the public school? There's no doubt it's another factor in trying to attract folks here.
And if you want to create some controversy, let's talk about the elephant in the room.
Well, there's no better person to do that than you.
I was going to say, speaking of cranky.
Well, that's what I had to say, but we went first. You know, we talked about policy and philosophy, but the practicality is we weren't great in the medical community because of a lot of things that we just talked about, but we got a looming crisis for Jackson Hospital sitting there. Baptist is not the answer in the long term. I think somebody told me, you said that we'd have to go find 30-some-odd hospitals around the southeast to be able to get all the patients that you couldn't take from Jackson. At the end of the day, you guys are the experts. What can our community, what can Jackson do, what can Baptist, what can we do to get in a position where Jackson's threat of closure, coming out of bankruptcy, gets removed so that we can move forward with health care in this community for the many thousands of people that don't have it, even now.
Not it.
Obviously, that's a very complicated question, right? I mean, no, so I don't know why, to be honest with you, sitting here, I'm not sure I know why they failed, right? And so, you know, and so that's really the question is, you know, if I understood that, you'd probably be able to figure that out. I mean, I know margins are tough for hospitals, and hospitals got squoze with increased expenses, especially around COVID. And really, as Ted pointed out, it's really hard to increase your on the revenue side without increasing volume. But if you increase volume, increase costs too. So it's really hard. Hospitals across the country really got their margins sort of squeezed during COVID. I mean, the government helped out a fair bit with funding, but once that funding went away, they were still left with very high nursing costs, for example, and very high supply costs. They got to buy eggs for the cafeteria too. I mean, so all of these things squeeze things. So I have to beg ignorance.
Let's talk about
I don't know.
Cooper Green, is it a negative, positive, or neutral to a public hospital? You know, we since time immemorial have never had it. Government, local, and state, and have supported Baptist, Jackson, and all the medical side of it, but we've never had a public hospital.
Yeah, let me go back to Jackson real quick. You know, and I'm not on the finance team at Blue Cross, so I don't have a window into what, you know, the financial situation is either. If I had to guess, I would guess that, that Jackson has a fairly high percentage of uninsured patients who come through the door. And going back to my original statement is, what business can stay afloat if you are having to give your services to, let's say, 10, 15, 20% of the people who are coming to access those services. I do think across the state, the number one thing that you could do, it's not a silver bullet, it's not going to fix every facility, it's not going to fix every healthcare system, it's not going to fix every healthcare problem. But I do think the first thing that you could look at and should look at is, how do we make sure that we have a smaller percentage of uninsured patients who are coming in to our hospitals? Because again, even though the population as a whole might have a uninsured percentage of X, the hospitals are going to see a higher percentage because that is those folks' only access to healthcare. So, you know, a higher percentage of uninsured people are going to be in those hospitals. So I do think that's really kind of first.
But you also
First
said
and foremost.
170 to 500,000 now have some means to be able to pay something.
Oh, absolutely. But there still are a fairly significant number of those who do not have any meaningful access to health coverage. And those are folks who I think are probably in this community showing up at Baptist as well. But my gut is a very high percentage comparatively showing up at Jackson. And if you could relieve at least that burden, I'm not suggesting that anybody makes money off of, let's say, assume it would be a Medicaid type reimbursement rate, you know, but at least you could staunch the bleeding some and get to where that's not. So I do think there's a start. With respect to sort of a public hospital like Cooper Green, my sense, not living in Birmingham, my sense is that they've made that sort of restructuring of their work pretty well. But you may have, with your connection with UAB.
I don't have a lot, other than that, you know, it's just sort of reopening and people are pretty excited about it. So, you know, having trained in public hospitals my whole career, you know, I don't know if that's the answer or not.
But you're prejudiced to those.
What's that?
You would be prejudiced to a public hospital.
Well, you know, I don't.
Chicago Med.
I know. I think that they serve a purpose. But I'm sitting here trying to think about whether I want my family to go get care in some of the ones I've trained in. You know, and so I'm not sure. And so that to me I'm just speaking honestly among friends. And so that's where the issue is. I heard the new charity is very nice. You know, up the one after they closed Big Charity and they moved the medical center of Louisiana. Now I heard that's a nice and well-run place, but I'll believe it when I see it.
What's the role of an FQHC with regard to the indigent care? Because it's sitting right next to Jackson.
And Gilbert is here, not to call you out here for Terry.
I think they should see all the indigent patients.
And there was $12 million put into his facility between the city, the county, and the state to create a offload for Jackson's medical emergency room. And actually, there's one for Baptist too, an FQHC that he runs.
That's a good question about that, Todd, because aren't you compensated higher on Medicare, Medicaid than maybe Jackson is? I think
We do.
don't you have a 3-to-1.
We do, I don't know if it's 3-to-1, but we do receive a higher reimbursement from Medicaid perspective, from the prospective payment system. But we are designed to establish it all over the state and all over the country to take care of the uninsured and underinsured. We do receive a small grant from the federal government, which is about 20% of our overall costs, operating costs, to offset the cost of uncompensated care. So we take all patients, insured, uninsured, homeless. We have mobile units that we take out into the community to go to the individuals who don't have transportation to come to a fixed facility. So we see everyone. The problem is we are primary care. And so all those specialties that Dr. Lambiase talked about, we don't provide, so we rely on a Jackson Hospital or Baptist to provide those services. So we work in conjunction with the local hospitals, because we're gonna diagnose people with cancer and kidney disease and those type things, which we don't have the specialties to take care of, so we rely on those facilities. So it still goes back to how do we save the Jackson hospitals and how do we ensure that our facilities, our hospitals are viable to help us take care of the uninsured and uninsured, because they will not have co-pays and those things to just show up to those facilities themselves. Now, we can't, even though we want people to stay out of the emergency rooms and come to us, that just doesn't happen all the time, but we are designed to see those patients.
Well, I think maybe one more, and then that's the
I'll throw one out. That lady wanted to speak over there. Yeah.
So this question is going to sound a bit like a mess coming out because there's a lot to address, but we've been talking a lot about coverage gaps, right? And how there's specifically a big rural coverage gap. A lot of people in rural communities, especially considering the Jackson situation, come to urban hospitals like Jackson for that kind of care because of lack of physicians and stuff. I think it's something like 40% of people that are treated at Jackson aren't actually Montgomery residents, they're from surrounding communities. But, you know, none of this, I guess, particularly, I don't want to say none of this matters because that's not the right word, but it's hard to consider the things when these institutions can't financially stay afloat, right? I don't know if you've seen, but a lot of what Jackson said contributed to their financial problems was an administrative issue in which they could not bill patients and, like you said, individual care and stuff. So I guess what my question is, considering all those things, is what like tangible steps and developments are insurance companies and physicians looking to take to address those like financial concerns? Like what like tangible direction are they moving in to address that? That's a big question, so sorry, but.
Well, I mean, Blue Cross, we've been working with the Hospital Association for about 6 years now to close the coverage gap and reduce, you never eliminate, but reduce the number of uninsured people in Alabama. Some of those discussions are a bit on hold, quite frankly, right now because of what's going on at the federal level and some concerns about how that funding shakes out. If we were to remain constant, like if the funding all stayed the same as it is today, we believe very strongly that a coverage gap solution is possible and affordable and sustainable over the long term that could reduce the uninsured population in Alabama by as much as 72 to 75%. Again, we think would have, it's not a silver bullet as I mentioned earlier, there are going to be other things structurally that are needed in the system. I know the Hospital Association talks a lot about the Medicare and the wage index, which is an issue for a state like Alabama. So there are multiple facets here, but I do believe, again, once we see this shake out, we've been partnering with the Hospital Association to find a solution for that uninsured population in Alabama. And our hope is, once the funding shakes out, we will get back to work on that and in discussions both at the federal level and especially at the state level.
Madam Chair, would you like to bring us to a close?
I want to thank you, Dr. Lambiase and Attorney Hosp, for this wonderful discussion. It's really all that we could do is considering all the issues you brought up. But we want to make sure that we are talking together. We all have to work together. That's the main message I got out of all of this, to try to support our community leaders as we find out answers to some of these questions that were raised here. Our Chamber's legislative update is a crucial forum for fostering dialogue between our legislators, business leaders, and community members. And it gives us insight. What this really boils down to is we have to continue to work together, come to these forums that we have here to discuss, but also move policy and options forward. I want to thank all of you for being part of this vital conversation. And we encourage you to follow our chamber website, the newsletter, and social media platforms to stay aware of opportunities to engage. Thanks to all of our sponsors, and thanks to all of you for coming, and have a remarkable afternoon. Thanks again to everybody.
I'm about to say bye to all of our